it's a huge issue that we all face, is how to get these referrals out of the channel. And so how do you think we best get the information out there, out of the otology, neurotology circles to the general otolaryngologists, the hearing aid dispensers, the acousticians, the audiologists, about the benefits of this intervention?
That's a great question, Brian. And I think we've battled with this quite a lot because we have our meetings. But the general bigger conferences usually attract a lot more generalists, so they are attractive for them. The audiologists are another key area because they will need to be aware. And when we did the Healthy Ears survey, we realized the awareness amongst audiologists is so low, whilst it's taken as a surgical device, so they don't consider it as an audiological solution, whereas it's a blend of the two. So having educated, or made, educated is a bad term, probably made audiologists aware, we are getting a lot more appropriate referrals. So the number of referrals which go on to surgery have increased enormously now.
I think all of us on here have a slew of patients with near maximum conductive hearing losses that we see over and over again to clean their mastoids, and we have the same exact conversation with them about, hey, I can really help this if you give me 20 minutes. And they say, I'm good, and they walk out of the office. And I'm wondering from all of you, if the dementia literature, if the work on cognitive decline and the growing body of evidence regarding treating hearing loss has changed the way you talk to patients and changed the acceptance of an intervention, or changed how aggressively you pursue that intervention with the patients. Anybody?
Well, this could be the case, but I think the important point is that we can give hearing to the patients, no? And it's probably independent from what we do for the ear, for removal cholesteatoma to make the ear dry, whatever. So we can separate the two things. I think in the past we were always saying, first make the ear dry, second improve hearing with our surgical technique. And we know about the results we get, even with very subtle surgical technique, you still have this kind of results we have seen. And so I think that has changed our thinking about serving those patients. As Doug said, I mean, we have to place our priorities, so to say, in a different way.
And in addition to that, sorry, you go, Doug.
Following what Professor Lenners just said, you can place an osseointegrated device and give the patient hearing while you're struggling to manage their draining cavity, where we've done that backwards before. And in the meantime, we've inflicted 2 additional years sometimes of hearing loss on patients. And you know, I'm in the United States, as you are, Brian, and we live in a world where litigation is a sport. And I've been talking to some of the local plaintiff attorneys in our area in Seattle, and they're very interested in the dementia data. So in all of my disclosures now, my templates I use when I pre-authorize a surgery, I include a mention of a discussion about the potential risk of dementia that is evolving in the literature. And so I do talk to people about it, but you have to be very careful that it's not viewed as a threat to the patient. Get a BAHA or you're going to get dementia, because there's plenty of demented people with perfect hearing and plenty of people with hearing loss that don't have dementia. So I'm sorry, Martha, I interrupted.
Well, I think it's perfect what you're saying, but I wanted to highlight another important aspect in this decision making, since actually you do not really have to convince the patients. Well, this is one of the implants that you can try before you buy or get surgery. It's so easy to, in your outpatient clinic, show it to the patient, use the test rod or the sound arc or another device, and you just let them hear what they can get after implantation. So in my experience, you do not need to convince or to, of course, it's important to highlight the aspects as previously mentioned by you, Doc, or by Jadip, but it convinces themselves. If they have hearing loss and they try it, they are so happy.
I think that's a great point, and it's also getting that information to the audiologist. And if they can capture that patient right after the hearing loss when they're having a discussion about potential interventions or hearing aids, if they could get a demonstrator on them quickly, that does more than most of the words we could use. I totally agree.
Exactly.
So the question for you was, what is the most urgent research priority to improve patient outcomes in chronic otitis media-related hearing loss?
Yeah, to repeat, to improve the quality of life in these patients.
Improve
So,
patient outcomes.
and with patient outcomes, yes. So what we have been trying to develop in the team of us together with this initiative, which I'm very grateful for, is that we believe it would be very the first step to make sure that you have investigated how the current states of treatment is, combined with the hearing outcomes and the quality of life. And then also in a prospective manner, change the participants in two arms, so to speak, because what we would like to investigate is to see whether this awareness can change at least or diminish the time without adequate hearing. So you at least offer them a conventional hearing aid or a bone conduction device at an early stage, and then follow up on them for at least a longer period of time to see how the infection is controlled or not, how the hearing is evolving, and what the impact is of this intervention in their quality of life. And this is what we aim with the study that I was shortly highlighting on in the introduction. And I think that's the first step.
I totally agree. Anyone else like to add anything to that?
Well, I think the other one could be on the indication, so that we probably also give some or find some, or let's say together can define some guideline. So you have a patient coming in and he has conductive loss. So would you do surgery? In which patients would you do just surgery for improving hearing? How often would you do it? Is it something we can really, so to say, set guidelines? Because I think that will come. You have cases where you definitely can improve the conductive component by surgery, and of course that should be clearly stated from our side. Then what are the criteria? And I think to pool data and so that we can really base it on statistical analysis would be also good, I think.
Yeah, the etiology for chronic otitis media is, of course, very broad. So it's indeed a very good remark to make sure that you specify the different indications, and for each specific indication, really quantify and qualify what the next step in this treatment should be to achieve hearing and carefree dry ears. So I totally agree with you.
Mm-hmm.
So Brian, I hate to kind of come back to my love in this whole game, and that is, my goal before I retire is to see that a significant number of patients are hearing that weren't hearing before I practiced medicine. And I think one of the biggest hurdles is funding and getting an awareness at a governmental level of the importance. And I think we have a couple of significant leverage points. The most expensive tsunami heading towards any government subsidized or government controlled healthcare situation in whatever country you're in is dementia. And when we look at these patients, as Professor Hall and Professor Lennartz have talked about, we're talking about negotiating with the governmental agencies who set the pace for negotiating pricing and reimbursement for the private sector. And the whole concept of risk stratification needs to be brought into this conversation. And risk not only and what seems to be very important to all insurers is the patient reported outcomes, where they're saying, yes, my quality of life is improved. The other piece to this is, are we actually keeping them from having additional surgeries by being able to manage them without operating on their chronic ear disease? And we haven't seen many papers talking about how many people we take from a dry cavity to a wet cavity trying to improve their hearing. And so I think approaching this as this group is very logically, starting with a large literature review, identifying areas that we need to bring clarification to drive the point of improved reimbursement, will improve patient access, will allow more people to hear, and will reduce people's risks for things like social isolation, which lead to things like dementia. So we need to be very logical, and I'm encouraged that that was one of the early talking points with this study group, as we're really addressing this issue. And I think just as cochlear implants have informed the biological research pathways, I think this technology improving hearing can improve the reimbursement pathway for all hearing technologies, including hearing aids. So I think that's a much bigger view, but I think getting data, including patient reporting outcomes and quality of life surveys, is going to drive that question home.
I totally agree, Doug. It's more than just decibel hearing improvement, right? It's how do we quantify the quality of life improvement? How do we improve market access and the health economic arguments behind the benefit? And there's dovetailing on what Dr. Hull was talking about earlier. As part of that standard of care, we have to be able to create the clinical evidence to support going to the regional and international academies to help create the practice guidelines to say, when should you, what Dr. Leonard was talking about, when should you be thinking about this solution as opposed to a third attempt at OCR or a revision stapedotomy, or pick a thing that doesn't have great typical hearing outcomes associated with it, but we need the evidence to be able to back that up, right? It can't be opinion based. So that's why this group is so important, I think.
And let me push back on the manufacturer a bit here. You're seeing very compelling data from Professor Lenartz's study at Hanover about the bone lines that are required for BAHA. And I think that needs to be pushed as well. And clinical studies in whatever markets we need to help improve or increase the number of people eligible for this technology is going to be very important.
Question for Dr. Thakkar. What patient factors should we consider when evaluating what treatment to provide for chronic otitis media related hearing loss?
What Asian factors?
What patient factors should you consider when evaluating which treatment to provide?
Well, I mean, we are in a very different spectrum in terms of the economic, economically where we are, and we're probably a couple of decades behind the other societies in terms of how our patients think and what we can afford. And implantable aids are not quite the first option for quite a for most of our patients for this very reason alone. So from our point of view, it is always an issue as to whether this can be sorted without an implantable aid and by surgery itself, as Dr. Lenartz talked about. But I think where ossiculoplasty or tympanoplasty surgery really fails the patient is something that is not often talked about, is that though the short-term results and the medium-term results can be fairly reasonable, in the long term, we do know that there's a fairly high incidence of conductive hearing loss recurring over an 8-10 year period. And I've had so many patients who have had these recurrences, not at the first time, but when they get onto their 40s or their 50s. And then you have a problem. And of course, the acceptance for other kinds of hearing treatments, which includes which basically includes the implantable hearing aids or even otherwise hearing aids, tends to increase then. So tympanoplasty surgery is not often a long-term solution. That is an issue there.
Mm-hmm. Yeah.
Would anyone else like to comment on, I think all of you have decades of experience in this space, and sometimes some of your treatment algorithms are unconscious at this point.
Well, the other point is also that we look on the cost side. Yeah. So, for instance, when you just consider the costs you have with kind of each surgery, and compared to the costs you will have with a bone conduction device. So I think one also should have one eye on this. Let's say we could look for cost benefit or whatever, but also just compare costs, yeah, between the different treatment options, and then also look on the result and on the duration of, let's say, a good solution, good hearing. Yeah? I think that would be also worth to be put into the discussion, and that would help also to promote the reimbursement. No? Because if you look on the numbers you have shown with the surgery, the cost for surgery, and then I think if you need to, you try it several times to improve hearing just by your tympanoplasty procedure and it fails compared to the costs you have for the BAHA device and so on. Of course, one has to look on lifetime costs or whatever the appropriate view is in order to get it right. But I think it's something we also should try to do. It's depending on your healthcare system and a lot of things in it, but still, it's I think worth to be done.
Would anyone else like to comment on how you think about whether it's an advanced otosclerosis with a mixed loss like Dr. Bacchus presented earlier, or a revision, a sacral reconstruction after a suboptimal result? Now that you have these bone conduction solutions available, how do you think through those options and present it to the patient?
Well, I think if you look on otosclerosis, for instance, and you have a clear case, there is conductive loss, and then you would go for stapleplasty, unless the patient is saying no, don't want to have the surgery. But if you have, let's say, cases as we discussed today with the chronic otitis, where you really have, let's say, a bad ventilation, there is probably little chance that you really can get an aerated middle ear back as a precondition for some improvement in your conductive component. Then the point is, okay, you will do the surgery to make the ear dry, but otherwise give the patient the hearing with your bone conduction device as early as possible. So I think that's what we really have to figure out and see that we get it right in the indication scheme and algorithm that makes sense and would be also widely accepted by, let's say, the community, also by the payers, and I think that's a goal we should have.
I find it easier to think with the patient, so you have verbalize your thoughts loudly with them to say everything's on offer: tympanomastoid surgery or a sacroplasty or staphydectomy, hearing aids and bone conduction devices. And the bone conduction devices give a predictable benefit, like Meta said, you try before you buy. But despite whatever you say, the patient might go for a tympanomastoid surgery because it doesn't involve an implant, which may be where Dr. Tucker is coming from. And then they say, well, if your surgery fails, is there still an option for a bone conduction implant? So that discussion is like Thomas is saying, has to be had frankly and fairly. And I think that awareness is lacking in a large part of otological practice. There are so many colleagues I know who don't offer any other alternatives apart from the middle ear mastoid or tympanomastoid surgery.
It's very fascinating to me, the power of a well-established pathway that the medical community accepts, and bringing that into the conversation with the payers. Whether that be going to the academies and getting position statements supporting those. If you have a good pathway, that is a great tool in ensuring the reimbursement. And I think and I completely agree with what Professor Ray just said. I think a lot of surgeons will describe the best option that they like to use, when indeed this is a good option. And I think where it comes out most blatantly to me is kids with auricular atresia. There's absolutely no question the best hearing outcome in an atresia case is with an osseointegrated device. Absolutely no question. And that decision about hearing can be made completely independently of a cosmetic reconstruction. So I go back to Charles Sims from San Antonio, Texas, telling me he's got a child. He did a auriculoplasty and a canalplasty on one side and put a BAHA on the other when she was about 7 years old. And she's now in her 20s and sees him every year, and every year tells him her better hearing ear is the BAHA ear. It's very humbling to him after his incredible outcome with a 25 dB loss in the surgical side. So, but I think a well agreed upon pathway will be a great power tool in getting consistent reimbursement with less pushback. Because when you talk to, I was just on the phone with some congressmen last week for our Academy, American Academy advocacy group, and it is just simply about the money. If they can spend money, deliver more to a patient, they will support it. And if it costs more money, but as Professor Lennart said, we've done the study to say over the first 10-year period, you're going to spend $25,000 less on this patient, they're going to understand that.
Yeah, they can have better access to work, and they can really actively participate in society. I think that's really important to add. Yeah. I'm sorry, Rafa.
Yep, absolutely.
I
All right.
think.
Go ahead.
Sorry, I think the conduction system is not a solution for every patient, but we know that 20% they are going to have bad results with surgery. We must know in which cases we are going to have a bad result with hearing, but we are still doing an heroic surgery. I mean, 2-3 surgeries, reconstruction, and we know that we are going to have bad results, but we are still doing it. That's the point. Is the importance of the guidelines. It's like a checklist for us and or for every ENT surgery to check and see. No, probably in this patient we are not going to have good results. Why not to do a dry ear and at the same time bone conduction system?
So, Dr. Yamamoto, while you've got the floor here, there was a question that came through for you. What do you view as the most important factors when counseling patients towards a blind sac closure?
Okay, the most important thing is when I decide to do a blind sac closure is how is the hearing and what is the pathology to perform this. I mean, when I have a inner ear malformation, I'm going to do a cochlear implant. It's okay. It's very easy to do it, the blind sac closure. The problem is when you have a cholesteatoma, that if you want to perform a blind sac closure, you must realize that you keep out all the cholesteatoma. Otherwise, you will have a cholesteatoma inside the cavity where you can see. I know that you can do an MRI and see if the cholesteatoma is coming up or a second look, but probably the most important thing is the pathology that you are going to treat with the blind sac closure.
Anyone else want to add anything to that? How you view blind sac closures in your treatment algorithm?
Well, I think the blind sac closure is something we really should do and keep in mind, because that could be the solution for a patient with a discharging ear and also eradicating the cholesteatoma. And if you go for, let's say, another implant, so let's assume the patient has a progressive hearing loss and you have to go for a cochlear implant, then that's our experience, the blind sac closure gives you a good protection of the cochlear implant, especially the electrode going to the cochlea. And so I think that is something one really should consider, even for the future of the patient. And it's, I think, a very well-established surgical technique. And if it's done well, then I think we have very good results also long-term wise, and give kind of safe solution for the patient.
Dr. Leonard, I think the final question here is directed towards you. You obviously showed the fitting range criteria. How big of an issue do you find is the challenge of providing sufficient amplification to those patients? And how many of the patients really fall outside of that fitting range? And how are you now approaching them?
I mean, you have seen we had a few that were basically not satisfied, and even with the superpower, we could not really get them over this line of 60%. Of course, you can discuss the 60% monosyllables, but we found this a practical, so to say, use line, because if the patient has 60% and more, then he can use this ear in everyday life. And of course, it depends on the language and so, but it's just in German language, that's what is valid. And so the percentage is, I think, less than 10%, but it depends on, of course, the patient you select. And we were, let's say, initially only down to something like 30, 35 decibels. And then we did extend it, see, stepwise. And then, of course, you also have some patients where you go over the limit. Yeah? And then I think you come to this data I've shown. I think with the improvement in the speech processors, we saw that we could serve patients well that could not be served before with the weaker, with the older devices. So I think the potential for bone conduction is very good. And if we stay, let's say, with the conservative indication as we have shown it, then we can serve a lot of patients. So I would say 10% are not satisfied, 10–15% for audiological reasons. I mean, you have some others with the percutaneous screw issue, but that is a different category. Yeah? But just for audiological reasons. And I think we just want to be open and honest and say, okay, then we will put this into our indication criteria and we stay with that, so that we probably don't use the concept of bone conduction.
Can I add one short sentence to that? Because I totally
Absolutely.
agree with you, Dr. Lennartz. But I think it's important to highlight as well that you, once you are very early in the history of COM-related problems, then you do not have the risk of getting more hearing loss due to the infection. The toxins of the infection are also causing hearing loss itself. Bone conduction related hearing loss. So sensory neural hearing loss, I mean, sorry. So if you are early in this disease, then you do not have a large challenge in providing sufficient amplification because of the fact they have a good cochlear reserve and they will benefit from the bone conduction devices once you use it early in the disease.
Yeah.
Good point. Great. Anyone else have anything to add to that? All right, well, we are exactly at the end of our 2 hours. I want to thank all of our panelists here. It's great having this distinguished group be able to come together again. And again, apologize for last time's technical hiccups, but I think this was really a fantastic exchange of ideas. We have just about every time zone represented here among this call. So for those of you where it's late at night and early morning, I appreciate you staying with us. I think this was really great on a first discussion and building the foundation of the discussion and clinical evidence of how do we use this technology to really change how we think about treating these patients and how do we best benefit them from a hearing standpoint moving forward. So thanks again to everyone. Kudos on staying on time. It's one of the first meetings I ever attended where every speaker stayed spot on time. So thank you again for doing that. And everybody stay well and hope to see you all soon. Bye-bye.
Take care. Thank you.
Thank you.
Bye. Take care.
Thank you for inviting us. Thank you.